memory is stored. So here is a little question that popped up. It says, if it's only limited to the brain, then does that mean that having diabetes does not increase your risk of Alzheimer's? And diabetes does increase your risk of Alzheimer's, but it's not because the brain has trouble taking up sugar, because it's a different mechanism. It's probably a risk for Alzheimer's because if you have diabetes, you have an increased risk of vascular disease. So you have an increased risk of heart attacks, you have an increased risk of strokes, and there's a very close link between your vascular health and the risk of dementia, including Alzheimer's disease. So it's probably more of an indirect link with diabetes, but they are separate processes, although conceptually they are a little bit similar. Okay, so I just showed you 4 diagnostic modalities. I showed you the PET scan, so we can do a PET scan for amyloid. That's the brain scan that I showed you, the CT scan. And I showed you there's some development now in doing PET scan for tau. And then the last slide I showed you here was a PET scan for glucose. So there's 3 types of PET scans that one can do to really increase the sensitivity of a diagnosis of dementia, especially when the symptoms are mild. And then the last diagnostic modality I showed you was a lumbar puncture. So 4 modalities. So how is that helpful? And this slide is perhaps, at least in my opinion, the most interesting outcome of those measurements, if you will, or those imaging techniques. So it turns out that if you look at these graphs, and I would just pay attention to the red one for now. There's just a red line on this graph. So on the x-axis, that's the bottom line, where it says preclinical. Think about that as someone in their 40s or maybe 50s. And then once you get into the stage called MCI, that stands for mild cognitive impairment. And that's usually a phase that precedes someone becoming demented. So that would be a phase where someone has mild problems with memory, for example. Not quite right. The family is noticing something isn't quite right, but they're still functioning fairly well, may even work still, but there's something not right. So that's what MCI stands for. And dementia is when symptoms get more significant. So if you follow that red line all the way from the left, it turns out that the changes in the brain that leads to dementia actually starts in your late 40s and early 50s. It's hard to believe, but that's what these imaging techniques have shown us. So there's a long period, and that period can be up to 30 years, where a person does not have any symptoms, so no memory problems, no problems at all, but the process that leads to Alzheimer's has started. 30 years you can go with being completely without symptoms. And then once you have symptoms, which is where you go from what's known here as preclinical, when you get into the MCI, you can see that the red line has almost plateaued. So that means that by the time you have symptoms suggestive of Alzheimer's, for example, the pathology in the brain that leads to those symptoms has almost saturated. So that has some implications for treatment, because as a lot of the treatments are being targeted, of course, to people who have Alzheimer's disease, who by definition have dementia. And it may be too late. We don't know that yet. And there are a lot of treatments now that are testing that question. But the pathology at that stage has gone on for a long, long time. And we're trying to determine whether we can remove all that pathology at this later stage. And the other thing that the imaging has taught us, so the PET scanning and the lumbar puncture, is that you can essentially take a person who is young, maybe in their 40s or 50s, and do one of these tests, and you can determine whether they are on this trajectory. So you can determine whether someone has the beginnings of Alzheimer's disease. Now it gets a little bit complicated. So what's not known is if you have say a 50-year-old with no symptoms, and you do a test and they have amyloid in the brain, what does that mean? Does that mean that that person will get Alzheimer's disease? That's unknown at the moment. Most of the data, though, suggests that if you have this amyloid in the brain, you certainly are at increased risk. Now, how big is that risk? We don't know yet, but it's certainly big. So this is where, just to elaborate a little bit more on that point, again, if you're 50, if you look at the left side of this graph, it just means that when you're 50 and have no symptoms, your chances of having a positive amyloid scan, for example, your chances of having amyloid in the brain is very low. It's almost zero, but it's not quite zero. But as you get older, and this means that if you took, let's say, anyone aged 70 to 80 in Vancouver, for example, or in British Columbia, if you randomly picked anyone between 70 and 80, about 25%, so 25 out of 100 in that group will have a positive amyloid scan, even though they have no symptoms of Alzheimer's or anything, no problems essentially. So obviously that causes some difficulty in interpreting what does a positive amyloid status mean. We don't know what it means yet in someone who doesn't have symptoms, other than that they are at increased risk, significantly increased risk. And a lot of the data have also indicated that if you have amyloid in the brain, your memory is not as good as someone who does not have amyloid in the brain, again supporting that diagnosis. But the definitive answer, as you can imagine, this type of testing has only been around for about a little less than 10 years. And if you're going to follow someone from mid-40s to 80, obviously you need more time to really determine what happens. So this is a slow-moving area, but we are now at least able to visualize what's going on in the brain and make some predictions in terms of who's at risk. What does this mean in someone who has mild symptoms? What does that mean in terms of developing dementia? So a lot of the questions that I get when people come to my clinic, usually those individuals have some mild symptoms. For example, there's been some forgetfulness or some mild symptoms. And then the question I get is, well, how long is it going to take to eventually get Alzheimer's disease? Or what is this person's risk of getting Alzheimer's disease given that he or she has mild symptoms? And this is where the imaging really helps us. So if you have a certain type of mild cognitive impairment, and look at this second bullet point here. And some of this, I think this is what Jan was mentioning before, some of this looks like it's a bit erased. But essentially, if you have MCI, or mild cognitive impairment, your risk of developing dementia, so the risk of your mild symptoms to develop into a more severe syndrome is about 12% every year. So it's pretty high, but it also means that over a 5-year period, many individuals have converted to dementia, but it also means that many have not. If you add imaging to this, so if you have a positive amyloid status, that percentage increases quite dramatically to 18%. So if you have mild symptoms and you come to my clinic and you happen to have one of these diagnostic tests, we can tell you that your risk is either lower or higher based on this imaging. And it's probably even more significant in someone who has not just mild symptoms in one area, and one area might mean someone is a bit forgetful, but everything else is normal. That would be a single area. Whereas someone who is forgetful, but they're also having trouble planning a trip or having some other difficulties, in those individuals, the diagnostic accuracy is quite a bit higher if you add imaging or a biomarker test to the workup. So in this case, you go from about 12% every year to almost a quarter, so almost 25%. And then finally, if you have a negative scan, it's also very helpful. It turns out that very few, in the grand scheme of things, very few individuals who have mild symptoms will develop dementia, even in their lifetime, if you have a negative biomarker test at that stage. So a negative test in some ways is almost more important than a positive test. And then another method it's worth mentioning, because there's all these news about precision medicine and genetics, and we come a long way with genetics. I think we still have a bit of catch up to do with cancer. But there have been several recent publications describing if you took all the known genetic risk for Alzheimer's and you piled it together, so all the genes that confer very small risk, but together they may confirm a bigger risk. If you put all those together, you can actually define groups that decline much faster than others. And this is really just a lifetime dementia risk, not just people who have symptoms, but in their lifetime. So you can see in this red, just follow this red line here. Let's say you took everyone in BC age 60 and you did genetic testing on all those individuals. You could tell a person that you are in this increased risk for getting Alzheimer's disease, around, it starts separating here around 70, certainly at 80. So you could argue, is that important? Well, from a clinical perspective, it may or may not be important. I feel that, at least my experience with people coming to my clinic, is that the more information we can give about what to expect in the next 5 years, I think that information is incredibly valuable. But from a therapeutic intervention perspective, at the moment, this hasn't made much of an impact. But all this is to say that we can now give you much more accurate information about what your lifetime risk of dementia is, and also if you have symptoms, what your risk of declining might be. And this is the one more example of this. So in this case, if you have mild symptoms and you happen to be in this upper quartile that has the most genetic risk, you can see they can really separate individuals. So if you follow the yellow line and the blue line, if you happen to be in the blue category with minimal genetic risk, and you come to my clinic and you have mild symptoms, I can tell you that because of your genetic profile, over the course of 100 months, you have very little risk, or at least in the 50% area of converting to dementia. Whereas if you're in this very high-risk group, you are very likely, in fact, almost 90% will convert to dementia over the course of only about 55 months. So again, it hasn't had a major impact on clinical practice yet, but we have the tools to answer this question now. When somebody asks, well, my husband or my wife has these mild symptoms, what should we expect over the next 5 years? And we can't really answer that well in the clinic at the moment. However, if we start utilizing these tools that are becoming available, they're not quite available yet outside of research, but the tools are there. So we can start answering these questions about risk, which I think, and we certainly need more feedback from people who do come to our clinic, but I think it's very valuable for patients and their families. So this is just to summarize that again. These are the different modalities we talked about: amyloid PET, there's the tau PET, there's the FDG, that's the sugar PET we looked at. There's biomarker testing through a lumbar puncture, and there's genetic analysis. So just to mention, none of these are actively being used in the clinic. They're relatively recent research, but the research indicates that they can be quite useful. And I would say the modality that we're closest to using at the moment is the biomarker testing. So we can do a lumbar puncture now. There's a study where we can share results. But these other ones are not yet available at least through public funding. We hope that will change in the next 5 years, but it's ultimately linked to intervention. So at least the provincial government and frankly governments all over the world, at least for now, they do not consider information for patients and their families enough to pay a lot of money for new diagnostic testing. So you can argue that that's reasonable from a socioeconomic perspective, but you can also argue that that's really depriving patients of the most up-to-date and relevant information for them. So it's still an ongoing argument, and we hope that we will see some movement on these in the province in the next several years. Okay, so I'm going to pause there, and I'm going to just give you an opportunity if there are any questions if you want to type in any questions, or if I don't see anything, yet. So I think we'll just move on. So again, we've done, I would say, a lot of progress in diagnosis. But I think the burning question is, what are we doing for new therapies? And that's the goal of all of us who are involved in this type of research. And I just want to give you a sense, because I think it's a bit frustrating for many of us to read news stories about promising therapies, and then it takes 5 years, and then you may not hear anymore, or it takes a long time. And I just want to give you a sense of why it takes so long. So these are the different stages of research. So actually, let me go back one slide. So it all starts with what we refer to as basic science. So I have a lab at U.B.C. where we work on some of these things. And all this means is that we're trying to, in a model system, and a model system can be cells or other things that would grow in the lab, we're trying to determine what causes Alzheimer's disease. So we're applying amyloid, for example, to some of these models, and we're trying to understand what happens if amyloid is there, what happens if tau is there, and based on that, we develop potential targets for new drugs. And that's how the drugs that are currently in clinical development, that's exactly how they were developed. So the next step is, let's say you have, so I'm going to actually pause for a second. There was one question here. There's some recent news about diagnosis dementia through the eyes. Yeah, there has been recent news. The problem with these stories is that it's a potentially promising therapy, but it's still in the research stage. So through several ways, you can look in the retina and look for amyloid. So there's a lot of work going on with that. And of course, that would be a less invasive and certainly a less expensive test. And there's also ways to look at the thickness in the back of the eye to see whether there's been a change in the thickness. So those are two modalities that are being explored. And of course, there's also a lot of work being done on a blood test. So can you develop a blood test for Alzheimer's? And there has been some promising data, but it's still too early to say anything definitive about that, at least compared to the other modalities that has received a lot more attention recently. So back to the stages here. So let's say that we found an incredible potential target in the lab. So the next stage, and then we develop a way to engage that target. So you can think of that as the drug, the potential drug. And then that drug has to go through a series of toxicology and tolerability studies to make sure that a human can actually consume it safely. And that takes many years to determine whether that's the case. And oftentimes, as you know, with medications that are already being taken, sometimes there are safety signals that emerge after a drug has been approved and then has to be taken away. So it is an ongoing process, but it's certainly very important initially in the development. And then there are many stages of testing. And I think this is important for you to know, because when you read about studies in the news, and unfortunately I think our news media, they're a little bit more, maybe for good reasons, they want the sensational news to come out. There's a blockbuster therapy that looks incredibly promising. The problem with those stories, at least to date, is that they refer to these very early stage studies, and these early stage studies are much smaller, so much fewer patients are being tested. And when you have few patients being tested, there's a great chance that your amazing outcome simply was due to risk, or excuse me, simply was due to chance. And there's also a great risk that your population was skewed in some way. Perhaps you drew all the patients who seemed to get much better on your therapy. Maybe you drew that from a certain part of the country, and you drew all the people who got worse from another part of the country. So we try to mitigate that, but you have to take these early study results with a grain of salt. And the media, unfortunately, they're not very good at distinguishing an early phase study from a late phase study. So if you see these terms being used, especially phase 2, because that's where most of the breakthroughs come, but they're also, all the breakthroughs recently have turned out not to be breakthroughs because once you test them more rigorously, they don't work. So phase 3, this is a typo here, it should be not phase 4, but phase 3, that's what's called a pivotal trial, and it's testing thousands of patients, often with Alzheimer's, if you're testing an Alzheimer drug, to see if it works in a large, relatively heterogeneous group, although with the same diagnosis. And if it goes well in that trial, then it may be approved for as a drug. And as you know, we haven't quite reached that stage yet with an Alzheimer drug, but there are some important advances. So I'm going to focus on 2 areas that are being addressed and that are ongoing trials. So the first cohort of patients are those that have either established Alzheimer's disease or have mild symptoms, and that's indicated by this box that you see on this slide here. So there were a number of studies that have come out recently. I think that one relatively impactful study that was published quite recently was a pill that Merck developed. And what that pill does is it stops production of amyloid. But if you go back to this slide here, oops, go back to this slide here. So I want you to think about, if you look at this red line, and once you reach where you see that where that box is drawn, once you reach that level of symptoms, then you can see that amyloid in the brain has already largely saturated. So what do you think happens if you stop production of this red line or amyloid? If you stop production here, what do you think will happen to that amyloid that's already in the brain? And the answer is probably once you have amyloid there, at least with this type of therapy that Merck produced, which it doesn't remove amyloid, but it prevents the production of amyloid, it probably isn't very successful because there's already too much amyloid that's being produced. And that's really what happened. So the pill was exceptionally good at stopping amyloid production, almost 90%. However, it had no impact on any cognitive symptoms, which of course is the goal of any therapy. Now, we don't know whether if you take this type of therapy in someone who does not have symptoms, who is just starting to build up amyloid, you don't know if it might help in that population. And I think that's where the field is heading. But as you can imagine, it takes a lot of time to conduct those studies, because if you go into a population that doesn't have symptoms yet, it might take 20 years for them to get symptoms. So you have to wait 20 years for any result. But at least in someone who has established symptoms, which is what we care about today, this therapy didn't work. However, there are some other therapies. And for those of you who come to our fora at U.B.C. or elsewhere, you may have read about this. This is a drug that's produced by a company called Biogen. It's called aducanumab, which you do not have to remember. But what's really remarkable about this drug, and this was published now a couple of years ago, is if you take a person with Alzheimer's, and you should be familiar with this picture now, the one on the left, that's an amyloid PET scan. So you're looking at amyloid in the brain. You can see this person has a lot of amyloid. And but remarkably, this picture on the right is that same person, but a year later after taking the drug. And you can see the amyloid is gone. So there are now several other drugs. There are now 4 drugs. There's a drug called gantenerumab. Eli Lilly has a compound, that's the LY there. And then there's a third compound that's being co-developed, which also includes Biogen. They're all attacking amyloid. And what's really remarkable is that all these 4 drugs do the same thing. So if you take the drug for a year, you can completely get rid of amyloid in the brain. It's really remarkable. And I say remarkable because there have been some very widely publicized failures in Alzheimer's drug development. And those were drugs that were also designed to target amyloid. And they didn't work. And it was all over the news, thousands of patients. But it turns out that they surely didn't work, but they also didn't impact what they were supposed to do. So they didn't actually remove the amyloid. So essentially you had an amyloid therapy that didn't remove amyloid, and of course it didn't work. So now you have 4 drugs that are exceptionally effective in removing amyloid in the brain. So the next question is, and this is the question that isn't answered yet, but it's what everyone wants to know, if you remove amyloid in someone with Alzheimer's disease, do you cure their disease? And unfortunately, I wish I could tell you the answer today, but that's ongoing. And there's a ongoing trial of all these 4 drugs. One is scheduled, as you can see here, to conclude next year, and we probably will have the results by 2020. So it's a little bit away still. The other drugs are the same. There are some that, especially this gantenerumab, it's being studied in a population that we know get Alzheimer's because they have a certain genetic mutation. So it's a familial Alzheimer's study. They're exceedingly rare, but that's an opportunity to see whether someone who doesn't have symptoms, but you know for 100% sure that they will get Alzheimer's disease, if you give this drug before they get that diagnosis, can you actually cure the disease? So all of this will be known, I would say, in about 2 to 4 years. We'll have an answer to this really relevant question. If we remove this Alzheimer's-associated pathology, do we cure the symptoms? And we're all hoping that it will, but it's certainly not known, and it's certainly not straightforward. So there are a couple of questions here. Andrew had a question about malabsorption and dementia. So there are some malabsorption symptoms, especially malabsorption of vitamin B12. That's a common cause of B12 deficiency, which can cause dementia, but is reversible if you treat it. That's why we always test for B12 if you go to a clinic. Other than that, it's probably not a major cause, certainly not a cause of Alzheimer's disease, but it can cause some treatable dementia syndromes. And then another question here, what stage of Alzheimer's would these 3 drugs be used? I'm not sure if you mean used or tested, so they're currently being tested in clinical studies. And that population, I'm going to go back on the slide here, that population is these guys here. So it's only being tested in very mild symptoms. It is not yet being tested in completely asymptomatic people. But there are some other drugs that are being tested in that space, except for this gantenerumab, which is being tested in a familial Alzheimer's cohort, in which case it will be before they have symptoms. So let me just show you this graph here. So this is the asymptomatic state. And I think all these treatments eventually will be tested in this area. But what they're trying to do is provide some evidence that they work in established disease, which quite frankly, all of us deal with established disease. I think prevention is really important, but there are tens of thousands of people with Alzheimer's today, and we really need to find a therapy for that with those individuals. And so that's really where everything is still being tested, and personally I'm quite grateful for that being the fact. So there's several studies. One of the most publicized study in this space is called A4. I don't know if you've heard of A4 before. It's a drug, or it's a trial that's being sponsored by Eli Lilly. And they are looking specifically at people who have no symptoms, but they have a positive amyloid PET scan. So in other words, they're individuals that have amyloid in the brain through testing, and they're now starting a drug to see if you have amyloid in the brain, can you change their course by treating the amyloid. And that study, we're expecting to see some results. Again, over the next 5 years, there'll be a range of results that would be of high interest for all of us engaged in this study, and certainly the people who are impacted by the disease as well. Okay, so I want to mention one thing. So and this is something I could have said at the very beginning, but we speak of a cure, but in essence, what we really are trying to do is delay the onset of dementia until a person may pass away from other reasons. And that's really the reality. So say if we could push the onset of Alzheimer's until someone is 100, then I think we've had great success. And it turns out that if you reduce or delay the incident, or delay the onset of dementia by 5 years. So that instead of saying a cure, if we could delay the onset of Alzheimer's by only 5 years, you drop the worldwide prevalence of dementia by half. So that's a big number. So if we can only delay the onset of symptoms by 5 years, we would cut Alzheimer's disease by half. So in many ways, that's more of a working diagnosis or working goal for us, so that rather than an outright cure, although of course that's what we all want to do. But keep that in mind, because some of these therapies that we will be talking about and some of the ones that are being in the news, the impact may not be huge, but keep in mind that we may not need a huge impact. We may just need a bit of a delay to have an enormous impact on Alzheimer's in the world. So there was let's talk about some other treatments. There was an interesting study in the news, and we talk about exercise a lot. We talk about blood pressure a lot, vitamin D, all these things. And unfortunately, there may be a recommendation today about doing something, then 5 years down the line, there may be another recommendation based on new studies. So you have to take these with a little bit grain of salt, and the impact seems to be relatively modest. However, if you reduce your blood pressure to roughly 120/80, you have a fairly significant reduced risk of having mild symptoms. And these are an asymptomatic sort of middle-aged individual. So we're talking a little bit about risk mitigation in middle age and prevention of dementia, which becomes important. We don't think, although we do care about blood pressure in someone who has established symptoms, it probably doesn't have a huge impact if you aggressively treat blood pressure in someone with an established diagnosis of Alzheimer's. But if you're in your mid-40s and early 50s, I think that you should try to keep your blood pressure as low as you can. There was a bit of a sobering study published about a year ago where they looked at a fairly large group, I think it was 1,000 people with all-cause cognitive impairment, which means cognitive impairment for any reason, not just Alzheimer's, and they put them on an exercise regimen. And unfortunately, the people who exercised didn't get better, and there was some hint that some may even get a little bit worse, although those numbers were, it was fairly subtle, but certainly didn't get better. So as you know, there's a lot of work being done on exercise in dementia, and I think that the safest conclusion from those studies at the moment is that if you are middle-aged, so again in your 40s and 50s, these things becomes really important in trying to delay the onset. Really important. I think the whole community would agree with that. So low blood pressure and exercise in middle age is incredibly important. I think the impact of these interventions, again, in established Alzheimer's, apart from physical health, which is important too, it doesn't have a dramatic impact on the disease course as far as we can tell at the moment. But stay tuned. There's lots of studies going on. And this is one of them where there are changes in the brain. So we've said for decades that, yes, you should exercise, but there's some pretty hard data to suggest that if you do exercise, you see new connections being formed in the brain, especially in the front of the brain, and that's what these colored images are showing. This is someone who had exercised who was above age of 60, and there are clear changes in the brain if you do a regimen. And the regimen is about 3 hours a week, or as we say, at least 30 minutes 3 times a week. I think that's probably the minimum of exercise that you need to have a beneficial impact on the brain. And it's not walking, it's aerobic. So you really have to get your heart rate up. So it's either very fast walking or swimming, stationary bike, and some who don't have joint problems might be on the treadmill. So I've listed a few other ones that we get a lot of questions about, and this is a slide I've used in the past. So ginkgo has not been studied for a long time, and it doesn't seem to have a tangible impact, again, in people with established symptoms. Vitamins, I would say almost everybody I see in my clinic are taking vitamin B supplements, and it probably, I never dismiss those who take those. I think that it's fairly safe, but there's no studies that indicate that unless those are low, so we do test for the levels, there's really no clear evidence that they impact the disease, unfortunately. The same is the case for fish oil, dark chocolate, green tea, red wine. Alcohol, as you may know, has been disputed recently that it's not good for anything. But these are probably not detrimental, but there's also no very clear, at least in established symptoms, very clear correlation with taking these and doing better. Those of you who know Pat McGeer, he sort of coined, he's a researcher here at U.B.C. who coined this inflammatory hypothesis in dementia. And there's a lot of evidence, if you look at just population studies, that those who were treated for an inflammatory disorder over time seem to have a less incidence of Alzheimer's disease. So if you're a person in your 40s and you had a lot of pain and you were taking Advil your whole life, it seemed that those individuals were at less risk for getting dementia. But it has been studied quite a bit recently, and I would say there's really, unfortunately, no evidence at the moment to support the use of an anti-inflammatory. In fact, some anti-inflammatories will make people worse. So you have to be careful. But at the moment, there are some studies being conducted, but we are not recommending anti-inflammatories such as Advil. So I have a question about coconut oil. We'll get to that. There is some fairly reasonable evidence, especially from a prevention standpoint, if you convert towards a Mediterranean diet, so more fish, vegetables, the right fatty acids. I think this was a bit of a repeat from before. There was a large study on coffee, so surprisingly, this really surprised me, the more coffee you drink, the better you do across almost anything we know of, including heart disease. Almost hard to believe. And it seems to be the same with dementia. I mean, the risk mitigation is very low, but for those of you who drink a lot of coffee, I don't think that you should be concerned about that. So we actually have, so I want to talk about coconut oil because a lot of people take coconut oil, and it's been very publicized. I think one of the reasons why it was so publicized is there was a person who was giving her husband coconut oil, and it seemed to reverse his dementia. So coconut oil, the important ingredient in coconut oil is something called medium chain triglycerides, and they're called medium chain because the back chain, which consists of carbons, is considered medium in length. So it's really just counting the number of carbons in the fatty acid determines whether it's a short triglyceride or medium or a long triglyceride. So in the case of a medium triglyceride, the backbone has to be anywhere from 6 to 12 carbons. So coconut oil has a lot of the 12 carbon backbone, so we call that C12. And it turns out that that's not very active, and it certainly doesn't do much for the brain, we think. However, it also contains very small amounts of shorter chains, such as C8 and C10. Now, those are much more active, excuse me. And for that reason, we and others have made an extract of those active ingredients, and we're actually recruiting at the moment for a study using that in patients with Alzheimer's disease. Now, I will say this. So the anecdotal evidence, so anecdotal just means stories from people who have been using this. This type of evidence has suggested that some people who take coconut oil are cured. So I will say under these fairly rigorous conditions, although I don't know who is getting what because we're blinded, we do know that some are getting the active drug. We haven't really seen in a short treatment course, we haven't seen really any effect of this intervention. So there have been longer studies using these types of interventions, and they suggest that they work, especially something like a ketogenic diet where you're producing something called ketones, and that's really what the coconut oil diet tries to do. So more on this, I think, in the future. There's a lot of interest in this in dementia. We're running several studies at U.B.C, and there are several worldwide studies. But we are mindful of switching to a special diet is really hard. So we're mindful of that. But on the other hand, if it really works, then it might change people's minds on using it. So that was an overview. Just, I would say in conclusion that we are only one study away from a breakthrough drug. And so far, that one study has not been successful. So every year there are a couple of very large, typically industry studies that report their results, and so far they haven't been positive. But I am, although I'm generally, I guess, an optimistic person, I think the field in general, we're feeling more optimistic that we're getting closer to finding something that's going to work. I think the drugs are getting smarter. We have better drugs that are being tested. So in some sense, it's a bit of a golden era, I think, for developing drugs for Alzheimer's disease in particular. And I think over the next 5 years, hopefully we can have a bit of an update in this sort of format in the next few years, and I can give you that update and tell you what happened to some of these promising therapies. But I do want to go back to a little bit to the basics. There are some really amazing things that are happening in the basic science, where how we model dementia and other conditions in a very individualized way. And I just wanted to give you sort of a little snapshot about what's going on in the lab. So what we can do now is we can take a simple blood draw. So anything that you go to a local lab, do a blood draw, and we can grow those cells in a dish. That's not new. But what is new is you can take those blood cells from an individual and you can actually turn them into neurons. So these are all derived from a person with dementia, from a single person with dementia. And it was from that person's blood cells. And now we've converted those cells into that person's brain cells. And we're actually growing these cells in the lab. And we try to understand, in someone who has dementia, are their brain cells different than someone who doesn't have dementia? Are they connected differently? Do they respond to certain things like stress differently? And we've never been able to do this before because obviously you can't sample someone's brain very easily. But now you can actually sort of indirectly do this by taking someone's blood cells. And this is giving us potentially a lot of information about new drugs. Maybe there are certain drugs that work for one person and not the other. And we hope that this will be a good way to look at drug development. So this was a video, but it's not a video for you, where you could just see the live network. These are all cells that are connected to each other. They're from a person, and you can kind of see how the brain cells communicate. So just to conclude, we have a lot of breakthroughs in diagnosis, even before there are any clinical symptoms, and we're trying to determine how useful that is for determining risk and whether we can treat at that early stage. We do not have a successful therapy for Alzheimer's disease yet, but there are many exciting drugs that are reporting over the next several years. So stay tuned. And in the meantime, these are things that, this sounds a bit cheesy, this next bullet here, but it's true. There's strong evidence for exercising. There's very strong evidence, at least for prevention, to eat a balanced diet. Good evidence to keep your blood pressure low, avoiding diabetes. And we didn't mention this, but staying socially active and trying to avoid not seeing people you used to see turns out to be really important to keep the brain alive. So those are important things to consider. And I also want to say we have all these exciting drugs. If it's relevant to you or your family or loved one, please contact us, because we are engaged in all these international trials. And it is an opportunity. There are pros and cons about clinical research and being in a trial, but it does offer an opportunity to be exposed to a drug before anyone else might be. So thank you for your attention. Again, I'm happy to take any quick questions. I know we're sort of at the end, but thank you for listening.
We have a question.